Welcome dental friends, this is the second video in the series about why you should or shouldn't do a MaxFax DCT. Today I'm talking about the things that I really don't like about the job, and I'm going to do my best to make this not be a ranty video because that's not how I feel about the job at all. But honestly, sometimes, a lot of times, I could really rant about this job. What I realised is most of the things I hate about the job isn't to do with MaxFax DCT itself, it's to do with a hospital environment and also what I'm like as a person, which doesn't seem to be compatible sometimes, but I think you'll see some of that when we get started. Let's go. The first thing I hate about working in a hospital is the amount of admin we have to do, and the IT as well. When you're in practice, you see a patient, write the notes, and you're done. Maybe you need to write a quick referral now and then, but that's pretty much it. When you're in hospital, sometimes you need to see a patient. It might not be something you're comfortable with, so you need to go and talk to the consultant about it. After you decide on the treatment, you need to write an online form about what needs to be done and other details about the patient. After that, you need to obviously dictate a letter to the referrer, and then you just do this 7, 8, 9 times for a whole morning or a whole afternoon, and it makes me feel a bit like a GP, and I don't really like that. You know, I did dentistry because I like being hands-on, and that admin side, whilst that's important, it just is not something I enjoy. And the computers are so slow and so unreliable. Sometimes it will just take 5 minutes to log in. Just on a whim, it just decides that day it's going to be annoying and it takes 5 minutes. At other times when I'm on the clinic and I need to do all this admin, a page just won't load for no reason. I just have to wait for ages. And when you're on call, you're already being pulled in 5 different directions by A&E, the ward, theatres, external callers, the department. You need efficiency to get anything done. And these computers just don't work. Honestly, I've sat there for 5 minutes sometimes trying to log in. It's just such a headache. Short term, this could just be the hospital you work in. It could be, but I work in 3 different ones and they're all the same. And despite the hospital being in the same trust, each one has a different program for the same job. You end up needing to know 15 different programs who all have different password requirements and all require them being changed at different intervals. And it's just such a headache versus being in your own treatment room and having one computer with one software. Oh, I miss that so much. And there's other little things, like if I'm in theatre and I'm writing a discharge letter for a patient and I click the template, for example, general discharge instead of GA day case letter. It's an easy mistake to make, right? All I do is just go on there, take off the template that I used and replace it with the one I wanted. Easy, right? Wrong. The program doesn't let you delete the template that you've made because you've made it now, and that's eternally binding. The only way you can get rid of that template is by calling IT and getting them to do it. But then obviously they ask you to email, and then you have to email them and wait for them to do it, which obviously can take hours because they're so busy, because the computer system's so rubbish. Meanwhile, the ward's bleeping you every hour because they've not got the discharge letter. And of course, that's the time that A&E are calling you about 3 different patients, and honestly, it just builds and builds and builds. And it's a busy job, don't get me wrong, but it could be so much easier if the computer system wasn't so shit. I said I wasn't going to rant, but I just can't help it when I start talking about some of this stuff. The next thing, which I think you've already probably picked up on, is that it's extremely intense. It demands a lot from you, but more than all that, I genuinely believe a hospital is one of the most frustrating places you could ever work. I honestly think sometimes that a hospital is a place where policy and admin trump common sense and efficiency. And yes, of course it's going to be less efficient because you're working with so many people on very complex cases versus being in a general dental practice where you're the person who prescribes the treatment, you're the radiographer, you're the person who does the treatment, you're the person who reviews them afterwards. It's all you, and that makes life so much easier, but way easier than I ever expected. I get why the policies are there. They're there for patient protection, and usually they do that very well. For example, if a patient comes in like this, and I've listed them for a surgery, and they need an incision and drainage intra and extraorally, and this actually did happen. We just finished doing the huddle, we spoke about what the patient was having done, that it was a right hand sided swelling, etc, etc. This patient had a bowling ball on his face, the swelling was that big. And I had to run to A&E because the patient had just come in with a mandible fracture, and I wanted to quickly clerk them and get everything ready just before I scrubbed into the surgery, otherwise I wasn't going to be available for another hour. I'm running to A&E, trying to get all this done quickly, trying to be efficient, and I get a bleep by the theatre team, and I pick up the phone, and they say, "Oh doctor, you haven't marked the surgical site. Can you please come and mark where the operation's taking place on his face?" This is the same patient who had the world's biggest swelling on his cheek, and I forgot to mark the site, and I was being called because of that. Don't get me wrong, I'm not questioning the intelligence of the scrub team member. Of course they know. They're calling me because they'll get in trouble if I don't mark it. But trying to navigate through all these hoops for every single policy in the hospital just makes the job so much more difficult. Another frustrating thing is because you're kind of the person trying to make everything happen, you're trying to deal with all these different teams at the same time, trying to get everyone in the right place for the patient's benefit. You're the guy on the ground, and if something that had to be done urgently isn't done, it's kind of your fault. You get the blame for it. And that's true even when really you've done all you can. I'm not saying I get in trouble when things aren't done, but it just feels a little bit embarrassing to have not gotten things done. And maybe that's a problem with me, I don't know, but an example of this is a patient urgently needed a CT scan, a head and neck cancer patient. At 8 AM when we have our handover, the consultant said no matter what you do, get that scan done. After the ward round ended, getting that scan done was my sole purpose in life. I called the CT radiographers, tell them this was a 12-hour request, it's been 14 hours, I need this done. They said call CT bookings, so I called CT bookings, and CT bookings said, "Oh, we have a slot of 4 actually, if you want that." "Yes please, I want that." So then I called the ward and say, "We have a slot of 4, we're going to have this done, please make sure they go for this scan." Phone down, go about my normal duties for the rest of the day. At 6 o'clock, the consultant calls me up, asks me to send him the results of the CT scan. I go onto one of the 7 programs in the hospital and I look up the scan, or I try to at least, because the scan hasn't been done despite all my efforts earlier. Despite all those phone calls, it's not been done. I did everything I could to get that done, but ultimately it wasn't, and it's kind of my fault. But, you know, I put all of the effort in to make sure it does happen, so there's not much more I could have done, but still it just reflects badly on me. You can't let that stuff get to you, really, and that doesn't really, to be honest. I mean, it frustrates me, but I get over it pretty quickly. But this whole thing is just to say that sometimes it feels like you're just running through quicksand. It really does, like, just try to get anything done. It's just so frustrating sometimes. I'm going to move on swiftly because I could just rant about this all day, and that's not how I feel about the job at all, because I do love it. Honestly, I really do love the job, so let's move on. The next point is equipment, and with this I mainly mean in A&E. A&E do lean on us quite heavily because, as you can imagine, a lot of trauma does include the head and neck. But the equipment that we have there is just not conducive to treating patients efficiently. We don't have dental syringes 90% of the time, and essentially anything we do requires local anaesthetic. So we have to take those lidocaine vials and manually draw it up into a plastic syringe with a new needle that we've attached. And I know it doesn't seem like a big deal, but when you're being pulled in 6 different directions, you've got so many patients, it's a stressful environment as it is in A&E. You need things to be ready for you, and they just aren't. Compare that with being in practice, where if I had a patient that I was doing a treatment for, my nurse come would always have everything ready to go. I wouldn't even need to blink and a local's there for me to use. And if I need her to help me in any way, she's there, ready to go. Whereas here, I sometimes get the patient to hold the light so that I can actually see where I'm suturing, because the lights nearly just don't really work half the time. And also I hardly ever get a bed to do lacerations on because they're so busy. So I just have to make do with what I've got, and it really is just a struggle sometimes. No joke, I've been asked to do lacerations when they've run out of suturing kits. Yeah. That's actually happened. The penultimate thing I want to say is that hospital, because it deals with obviously quite complex cases, there's a bias towards planning over action, and I get that. That is the way these cases should be approached. However, a big part of me does just miss the time where a patient comes in pain, I can see what tooth it is and I can get going like that and just treat them. That's what I enjoy a lot of the time. If you're the type of person who likes to kind of be in control of a treatment plan and likes to get on with treatment immediately, then maybe hospital isn't for you. The final comment I want to make is on de-skilling in dentistry. When you've been out of the game, obviously not doing any restorative dentistry for 8-9 months, or a year by the time you finish, a lot of people will be worried about de-skilling, and yeah, I guess you wouldn't be as competent as you might have been at the end of your FD year, for example, if you're doing certain treatments. I think this would be a disadvantage depending on what DCT post you do. However, for me personally, even though I've done MaxFax and there's not been any restorative dentistry whatsoever, the confidence that I've gained from doing this post, like I said in the last video, which if you haven't seen it, I'll just link it up here, the confidence that I've gained as a clinician makes me feel like I'll be absolutely fine to pick up a handpiece again, because I've done things which are equally technically demanding, under much higher stakes, with far less sleep, and at the end of the day, a tooth is a tooth, whereas I've had to stitch up people's face after their dogs ripped half of it off, you know, and if you can do that, picking up a handpiece is no big deal. I say this very confidently, but my first composites are going to look like absolute when I first start back again, if I go back into practice. Despite all the things I've just said about how frustrating the job is and all the shortcomings, I have loved this year. I have no regrets about doing it. I would make the same decision 100 times over, and I really do think most people would benefit from doing a year of it. Other than if you're very certain about what you want to do next year, for example, if you're excited about becoming a more competent associate and doing treatments much more quicker, private treatments, aesthetic dentistry, if that sort of stuff's for you, then maybe you wouldn't get as much out of it. But at the very least, I think you'd be a lot more confident clinician than you were previously. DCT2 is coming up, and I would love to get an oral surgery post. However, I know they're super competitive, so failing that, you will see me doing MaxFax again if it's in a good unit. If that doesn't work out, I'll go be an associate for a year, and I think I'll do much better now than I would have if I'd just gone into being an associate after my FD year straight away. That's it from me, dental friends. I hope you enjoyed this video. I hope it was helpful. If you enjoyed the video, then give me one of those bad boys. Subscribe if you want more content like this, and I will see you soon. Take care.